Good morning, dear colleagues and faculty. Today I am going to talk on the topic liver transplantation for alcohol-associated liver disease. Why ALD is different and why you are concerned about the transplant in ALD. Basically, ALD has a stigma associated with this one, that is basically structural, social, and the self. Structural stigmas can lead to limit the access to the treatment for patients with alcohol use disorders. These patients, because of it is self-inflicted disorders considered by some people, so they may be excluded from the society, and this can lead to some of the psychiatric disorders, especially low self-esteem, hopelessness, and it can lead to anxiety and depression. All these factors, even among the health professionals, also some of about the negative stigmas about the alcohol use disorders can lead to delayed referral, which can lead to these patients present at the sicker stage, and also limit the selection of the ALD patients for the liver transplantation. To avoid these stigmas associated with the alcoholic liver disease, recently there is a consensus report has been conducted at Dallas, that is Dallas University in US. So to avoid this, they have changed the terminologies from the alcoholic liver disease to alcohol-associated liver disease, alcoholic hepatitis to alcohol-associated hepatitis, and alcoholic from it is to alcohol use disorders, and to recidivism it has changed to the alcohol relapse or return to the drinking. So now see what is the current status of the liver transplant. As we know, the alcohol liver disease and disorder is the most common cause of death in patients with liver diseases, especially in young patients who are less than 40. And this has led to, and some of the landmark publications which has been published in NHM 2011, and recently the Accelerate AH study which was conducted in US in 2017 has, and plus the COVID pandemic has led to increase in the waitlisting registration of the patients with especially alcoholic hepatitis and patients with alcoholic liver disease. There are almost 300%, more than 300% change from the baseline in the registration of the patients for the alcoholic hepatitis, and the ALD has surpassed the combined number of the NASH and SAB for indication of the alcohol-associated liver disease. What are the graft and the patient outcomes in this group of patients which are more and more increasingly perform liver transplant for alcohol-associated liver disease? This is the recent publication from JAMA published in 2019. This is a retrospective analysis from the UNOS database from 2002 to 2016. Basically, it is from the deceased donor liver transplant, and they have analyzed more than almost 30,000 patients in this alcoholic liver disease, consist of around 9,000 patients. The 5-year survival was close to 80%, and the 10-year survival was almost close to 60%, which was almost the ALD. They compared the survival among the ALD and other etiologies. It was comparable. But however, this increasing transplant numbers in alcohol-associated liver disease also increase the disparities in the waitlist registration, especially for the black patients, rural patients, and the poor patients, because of the lack of the insurance policies. Also, there was a lack of transparency among all transplant centers in the US. There was a heterogeneity among the regions, some of the regions performing more transplant for alcohol-related hepatitis. This was a recent internet review of the websites of the US LT centers performed by 3 undergraduates, and it was total 141 centers. They were assessed the data, and none of the centers they have given the detailed criteria based on the substance use disorders or the psychosocial profile. Any eligibility criteria was mentioned in 51% of the centers. Any discussion of the alcohol was present in the 17% of the centers, and only 2% of the centers they mentioned the 6-month abstinence rule is required for the registrations. Let us come to the history of liver transplant for alcoholic liver disease. The first, it was from the Starzls Institute. They have performed almost 73 patients underwent liver transplant for alcoholic liver disease. Out of that, 11 patients were less than 6-month abstinence, and there was a similar survival and relapse rate between the patients who are abstinent and non-abstinents. And they concluded that after with NIH consensus conference in 1983, that liver transplantation may be considered for the life-saving in the patients with progressive liver failure despite the maximum medical management and abstinence from the alcohol. Subsequently, even the same Stardust Institute, they interviewed the 50 alcoholic patients transplanted from 1980 to 1988. They reported the 43% alcohol relapse in patients with less than 6 months of abstinence versus 6.7% in patients who have more than 6 months abstinence. Similarly, there was also the experience was coming from the UK, especially King College and Cambridge. They transplanted 18 ALD patients. It was less than 5% of the total transplant pool. And 3 patients were without abstinence and all 3 had post-LT relapse. So they concluded that for the transplant to get registered for the, especially in DDLT scenario, the minimum period of 6 month abstinence is required before transplantation. Until recently, most of the centers in the US and the UK were following the 6 months rule for the registration for the transplant in DDLT scenario. But the 6 month, basically the 6 month rule was arbitrary, and it was proposed for with the aim of the two aims. Basically, we give sufficient time to recover the alcoholic associated injury and to prevent the relapse post transplant. But the select, especially in sick patients, we have higher MELD score. Now we are seeing more and more young patients with a high MELD score, more than 20. We have a shorter abstinence period. It is a life and death decision to go for transplantation. This is a recent publication from the US only. It has compared the patients with undergoing transplantation and the no transplantation, which basically received the medical management. The most of the patients, if you see the literature, most of the patients who recover, they usually recover up to 3 months, and after that, after 3 months, the recovery remains plateau. And in high MELD patients, especially the patients with severe alcoholic hepatitis, most of the mortality occurs in 6 months. That is close to more than 50%, that is close to 70%. So obviously the transplantation has survival advantage in this group of patients which have high MELD and more sicker, who don't have much long time to wait for their injury to subside. Even these patients, alcoholic liver disease patients, the recovery is often not complete. If you see the recovery, only 20% of the patients, they will achieve the compensated states. More than almost 70% of the patients, they require persistent medical management for recurrent HE, ascites, and especially patients who are sarcopenic, they are poor quality of life. This is basically because these patients are underlying advanced fibrosis and cirrhosis, which leads to they requires multiple OPD visits. So in this patient, usually these patients needs over the time they have poor quality of life because of the ascites, recurrent HE, and the liver transplant has obviously upper hand as compared to the medical management in these patients. So thus, based on this, that 6 month rule was recently challenged by, this is a landmark publication by French and Belgian group. It was performed the early liver transplantation for the severe alcoholic hepatitis. It was total 46 patients which are randomized into 26 in the medical management and the 26 in the liver transplant group. The patients underwent transplant, which is a non-respondence to the medical management. The first episode of liver decompensation, they have good psychosocial profile. They didn't have any severe significant psychiatric comorbidity, and it was a patients, they have agreement to adhere to lifelong abstinence. And they have showed that it has almost 75% survival advantage in as compared to the patients which are not receiving the transplant. What we have learned from this paper is that these patients are highly carefully selected. Only 10% of the patients had a favorable psychosocial profile. During the study period, they have performed almost 800 transplant, and this group consisted of less than 3% of the total liver transplant. So this number is not very large, it is a very small number. And most important thing, that post-transplant 6 deaths were due to invasive aspergillosis. So these patients, because they received steroids, so patients who have good psychosocial profile, they should not be pushed too far, otherwise they will have increased risk of sepsis, especially fungal sepsis in the post-transplant setting. They reported very low relapse rate. Only 3 patients had an alcohol relapse, and all the patients, they had a relapse after 6 months. Subsequently, this was an experience from the US, and this was American consortium from the early liver transplantation for alcoholic hepatitis. And this was, they did not have any specific abstinence period, and mortality without transplant was 70% at the 6 months. They have analyzed the survival and the sustained alcohol use at 1 year and 3 year. They are excellent patient survival and the graft survival at 1 year of 94% and 3 year of 84%. The sustained alcohol use, that was defined as continuous alcohol use for more than 100 days, it was 10% at 1 year and 17% at 3 year. Also, the cumulative rate of alcohol is, obviously, if you increase the follow-up, obviously the relapse rate will increase, and it was 33% at 3 years. Interestingly, in one of the 146 patients, the explant pathology available, and 90% patients had cirrhosis. That suggests that these patients were end-stage liver disease with superadded with liver leading to acute presentation, and the patient didn't had a less than 6-month abstinence. This was again recently published data from the Johns Hopkins University in the JAMA. Also, they have compared the patients undergoing early, that is less than 6 months of abstinence, versus standard, that is more than 6 months of abstinence for the liver transplantation. They compared the graft and patient survival at 1 year and 3 year. It was almost close to 80% at 3 years. Also, the relapse-free survival was similar at 3 years. This early patient transplant group, obviously, both had the underlying cirrhosis was comparable in both the groups. Patients undergoing early transplant had additional component of alcoholic hepatitis. They were younger patients, and they were high MED scores as compared to the patients undergoing standard liver transplantation. Let us see what is the public opinion regarding early transplantation, especially in patients with severe liver dysfunction undergoing transplant. This was a recent survey performed in the US. The total included 503 participants, and they were interviewed regarding the opinion for the early liver transplant centers performing the early liver transplant for patients with severe liver dysfunction due to alcohol disorder. And regarding the organ donation, the 68% of the participants intended to be organ donors, 21% were unsure. 82% indicated that they would be at least neutral to the news of nearby transplant program performing early LT for the patient with alcoholic hepatitis. And indication of LT for alcoholic hepatitis may not be as controversial as previously thought. Lots of the participants, they supported that the transplant should be performed in a younger patient, and younger patients were given more preference as compared to the psychosocial stability and the financial stability, and the psychosocial stability was given more preference to the financial stability. So, what is the question? Is the early LT is a good indication for the severe liver dysfunction related to alcoholic liver disease? Yes, answer is the yes, because there is no therapeutic alternative in non-response to the medical management. They have very high mortality, it is close to 70 to 80% in first 6 months. In highly selected patients, is the strict selection mandatory with the objective criteria. And experienced team, because these patients are more sicker and they associated with organ dysfunction, the survival is excellent, and the alcohol relapse, especially in the field of liver transplant for alcohol liver disease, this is acceptable. These are the experiences of the high volume centers for the early liver transplant performed for the alcoholic liver disease. These are the DDLT, initial are the DDLT experience from the recent experiences from the, just I told the Accelerate AS study, and recently has been published in Lancet 2022, that is gastroenterology and hepatology by again the French and Belgian group, which is a prospective non-randomized study. They have randomized into 3 arms, especially early transplant and the standard transplant and the patients receiving medical management. All these studies, the DDLT studies, they have reported excellent midterm graft and patient survival, and some of the studies have reported very good 5-year survival. These are 3 LDLT centers, the high volume centers, that is Medanta. From our experience also, we have published in Journal of Hepatobiliary Pancreatic Sciences, and recently AIG has also published for early liver transplant for the alcoholic liver diseases. We also reported the excellent 3-year and 5-year patient survival, and the sustained harmful use in our this one was almost less than 2%. Other studies have also reported up to 34% regarding post-LT alcohol relapse. But all these are the single, some of them are multi-center, majority of the single center studies, and most of these relapses are the self-reported, it may be underestimated. Next important things in alcoholic liver disease, important to mention, which have concomitant SCV, and the patient especially who have pre-transplant AKI and HRS, because we are seeing more among young patients, we have alcohol-associated liver disease with SCV co-infection. Basically, this was adult to adult living donor liver transplant data from the USA. They have analyzed the patients undergoing LDLT for the alcohol versus non-alcohol. They have compared the 5-year and 10-year graft and patient survival. That was comparable. Almost 5-year was close to 80% and 10-year was close to 60%. They analyzed they did the univariate and multivariate analysis for the practice predicting the graft survival, and they found that concomitant SCV infection and the preoperative renal dysfunction had a negative impact on the long-term graft survival, because SCV associated with the leads to advance. Along with alcohol, it accelerates the graft fibrosis, so they have more bad course post-transplant. And we know AKI and HRS associated with the cirrhosis had a negative impact. Patients with alcoholic disorder, they usually have coexisting substance use, especially the smoking and tobacco use, and they also associated, some patients are associated IgA nephropathy, so they have underlying CKD component. So this patient should be referred early for the transplant evaluation. So now, this is one of the, what is the difference in the alcohol relapse between DDLT versus LDLT? This is a Korean experience from the Samsung Medical Center. They have compared the relapse between DDLT versus LDLT. They performed 47 DDLTs and 82 LDLTs. They defined alcohol relapse of any use of alcohol post-transplant, and they have analyzed the alcohol relapse at 3 years. It was lower in the LDLT, that was close to 14% versus 32% DDLT. Obviously, in LDLT group, most of the donors were the spouse and the first degree relatives. They have emotional impact, so they have lower alcohol relapse at the 3 years. It was reported the highest, that is close to 55% for the current smokers without 6 months sobriety undergoing DDLT. In LDLT, the duration of the the duration of the abstinence period doesn't have impact on the post-transplant alcohol relapse. It was 70.7% versus 11.6%, but there was a difference between the current smokers versus non and ex-smokers. In current smoker, it was 22.4% versus 5.8%. So it is that important that patients undergoing LDLT, especially alcoholics which have active smoking history, we need to be carefully evaluated for the psychosocial aspect and the substance use disorders. Now see the rates of post-transplant. What is the important concern about the alcohol patient? We are doing liver transplant for the alcoholic associated liver disease is the post-transplant alcohol relapse or return to drinking. If you see the literature, the 1 year post-LT reported rate is 8 to 22%, 5 year is 30 to 40%. It is very large range because there is a lack of standardization to describe the alcohol use in the literature, and up to half of the patients with the recurrence have harmful pattern. Different studies have used different definitions, and we don't know whether the frequency and the amount of the alcohol has impact on the alcohol relapse. And the rates are mostly underreported due to reliance from the patient on the self-report. So what is the, why you are worried about? Because the post-transplant alcohol relapse can lead to graft injury, it can cause hepatitis, fibrosis, and can lead to graft loss also. So does it really important? So recently, this was previously also published by DiMartini, which has reported the patients who have 6 months of abstinence period, they have reported the patterns of alcohol use. Similarly, recently the Accelerate AS, that is a US study, previously I talked about, that they are undergoing 146 LT early transplantation for alcoholic liver disease. They found the 4 patterns of the alcohol relapse. The 70% patients remain abstinent, 6% patients had a late and non-heavy use, and 15 patients had moderate early use, and 8.2% of the patients had early heavy use. What is that is the impact on the post-transplant outcomes and the graft outcomes? The 100%, the late non-heavy use, the 100% will survive. In abstinence patients, we have 95% 5-year survival. And especially early, moderate to heavy use, they have accelerated graft loss. Almost some of the studies are reported 30% of the patient they develop accelerated cirrhosis. So, the what what is the important to learn from this? The transplant team should focus, because the alcohol liver disorder is a chronic relapsive condition. Some of the patients are sorry, going to relapse. So your focus should be to prevent and predict the patterns that will affect the clinical outcomes. So, what are the factors which influence the risk of post-LT alcohol use of recurrence? It doesn't depend on the single factor, that's the length of abstinence. Multiple factors come into the picture, like length of abstinence, social support, especially the spousal support in Indian scenario, history of polysubstance abuse, importantly smoking and alcohol, the relatives drinking, continuously drinking, having alcohol use disorder, prior failed treatment sessions, continued alcohol use despite after getting treatment for alcohol associated liver disease, alcohol quantity consumed, the insight of the patient to the adherence to the long-term abstinence, alcohol-related legal issues, and psychiatric comorbidities. The social worker, most of the important our setting, the nursing staff, the psychiatrists, and the addiction specialists should provide the risk assessment in all this aspect, and they should provide a summary about regarding the transplant team, which can help in the selection of these patients for the transplant. There are some of the studies which have reported the factors predicting the post-LT alcohol relapse. The first study is in a DDLT scenario. They have reported the 3 factors, that is decline to participate in intensive OPD patient program despite the recommendation, relapse after initial attempt at abstinence, and the patient who have stopped drinking, they have longer post-transplant abstinence. Even we have analyzed the factors predicting post-LT alcohol relapse, and we have revealed that pre-LT relapse, the duration of the abstinence, absence of life partner, concurrent tobacco or smoking, donation from the second degree relative, and the poor compliance, post-transplant poor compliance with medication associated with the alcohol relapse. So we need to have the standard psychosocial evaluation for this patient. The initial evaluation should be done by the specialized experts in the substance use disorders. We should use not the subjective criteria, we should have objective and consistent criteria. We have used to the adjunct tools, I will come later, which are externally validated. We are accurate in predicting the post-transplant alcohol relapse. And the transplant team should be sensitive to the existing stigma, disparities, and potential biases. And there should be a consensus decision, and we should have a multidisciplinary approach involving hepatologists, surgeons, psychiatrists, addiction specialists, nutritionists, and the nursing staff. And the single voices should not be driving the decisions for LT in these patients. So we should have a comprehensive psychosocial assessment, evaluating this patient in all the domains. We should use objective measures like SAPAT score and the SALT score. So we should know especially we target the population, we have high risk features like prior relapse, ongoing alcohol consumption, concomitant polysubstance use, and failure to engage in the treatment. And prior decompensation has been reported previously as absolute contraindication, especially in patients with severe alcohol hepatitis. But some of the recent studies from the US, though these patients have increased risk of mortality and increased risk of alcohol relapse post-transplant, but if you compare the medical management versus transplant, they have better short-term survival at 3 years, close to 75%. And recently, Dallas consensus, it has also has told the similar approach. Basically, you assess this patient on psychosocial. This one, patients with good psychosocial profile should be considered for the candidates for the liver transplant. Basically, it takes into consideration the consideration and the perspective of all the stakeholders which are involved in the transplant team. We can achieve the consensus, and the progress is possible in this, especially the sickest patients which are on the wait list. Some of the important tools I will discuss, that is SALT score and the SAPAT score. Basically, it is a sustained alcohol use post-transplant. It assesses the 4 variables, that is number of drinks, prior failed rehabilitation attempts, and history of prior alcohol-related legal issues, and history of polysubstance use. Basically, it is the score ranges from 0 to 11, and multiple studies have shown that score more than 5 associated with the increased risk of post-transplant relapse. It has a very good negative predictive value of 95%, and this tool is very much helpful to predicting the patients which have low risk of relapse post-transplant. And most of the centers, almost more than one centers in the 380 centers in the US are using this tool prior to transplant to predict the post-transplant alcohol relapse. Next is this SIPAT score requires very short time to assess, hardly requires any 10 minutes. Next is the SIPAT score, that is Stanford Integrated Psychosocial Assessment for Transplant, initially derived in the 2012. Basically, it assesses the patients on the 4 domains, such as psychosocial stability, adherence of the patient, polysubstance use, and the social support. The maximum score is 110, less than 20 is excellent, and more than 40 is a poor candidates. And multiple studies have shown the score more than 21 associated with the increased risk of post-transplant relapse. It is slightly tedious. It requires more time to assess all the 4 domains, approximately 30 minutes. This is a recent publication, that is quick trans method, that is basically it is a combined French and Belgian multi-center approach. They have come to the dedicated algorithm. This is a prospective non-randomized study which in the patient divided into 3 arms, that is early transplant group, standard transplant group, and patient receiving medical management. And they assess the alcohol relapse rate at the 2 years. A dedicated algorithm based on the given points to the multiple domains, that is absence of severe comorbidities, past medical history of decompensated cirrhosis, psychiatry and addiction evaluation, that is absence of psychiatric disorder, and that is a Bovip-Q test, is basically impulsive behavior is known in alcoholics. That is evaluation is done. Evaluation of the family support, subjective evaluation, and finally the assessment by the liver team for the evaluation of the family support. The total score is 250, and the patient is qualified for the transplant if the score is more than 210 points. Interestingly, the patient is assessed at the multiple levels, including nurse, resident, fellow, addiction specialist, senior hepatologist, and finally surgeons and anesthetists before listed to the transplant waiting list. And they have reported equivalent survival in patients close to 80% at 2 years in patients undergoing early transplantation versus standard transplant. And the alcohol relapse was slightly higher in the early transplant group, that is close to 34% versus 25%. It was, though the absolute difference was 9%, it was statistically non-significant. As I told, that our focus should be not more to the identifying the high risk population and to prevent and treat their alcohol relapse post transplant. This was a recent publication by the Toronto group. They have come up with relapse prevention therapy in patients with alcoholic related cirrhosis. Basically, they
try to summarize.
Okay, yes.
Yeah,
I'll just few slides are there. So, 100 patients and the 46 patients were underwent transplant, and they have reported a very low relapse rate with integrated post-transplant relapse prevention therapy. Only 3 patients relapse had alcohol relapse. The future is in artificial intelligence. Recently we have come up with the artificial model which predict the post-transplant relapse. Especially it is set with the example patient with low risk, moderate risk, and high risk. So especially patient is full in encephalopathy patients, but it has a very wide confidence interval. And 8 of the 13 questions in the final algorithm were related to the social support and the substance use. Potential usage, it has a high positive predictive value, and we give a continuous value for harmful alcohol use, allow the center to define thresholds for high versus low risks and estimate the uncertainty. Especially useful in encephalopathy patients where we are not able to assess the risk for the post-transplant. Important things to be remembered in this group of patients, it is chronic lapsic conditions similar to hypertension, diabetes. They are often comorbid with the psychiatric illness, nicotine dependence, other substance use, poor health habits, and low literacy. And we believe that usually they should undergo one addiction treatment and they remain lifelong abstinence. It is not like that. We need to have repeated counseling. These patients have higher rate of acute illnesses, organ rejection, and they behave like more NAFLD post-transplant. They have higher cardiovascular diseases, cancers because associated smoking and tobacco use, and higher mortality. They are usually resistant to accepting AV treatment because they feel it is not needed, and they are too preoccupied with the post-transplant care. So we can still do better. That is, we should consider the continuous spectrum as alcohol use disorder, And in this one, that is prior to transplant, you should have early referral so that we have got a sufficient time for the evaluation on the psychosocial and the substance use. Especially in LD setting, sometimes donors is not ready, so we get a time for optimization. And the selection process should be based on the good psychosocial profile. Post-transplant, you should have continued alcohol surveillance. Recently, we have available that is phosphatidylethylone biomarker, which is assessed in serum. It has good sensitivity and specificity, and close to almost 80 to 100%. And it can be used every 3 monthly, especially in first 2 years. After that, based on individualized approach. We have targeted intervention pre-transplant and the post-transplant for the slips and relapses, especially the treatment by the psychiatrists and addiction specialists, Alcoholic Anonymous meets, and pharmacology therapy in the form of naltrexone, disulfiram, or the gabapentin. And we need to have long-term follow-up these patients to more objective report of the relapse rate. This is IL-based experience. We have performed total 1,000 plus transplant, and for alcoholic CLD we have performed 349. Again, there is a post-COVID, there was a rise in the patients with because of the lifestyle changes and the harmful drinking, the rise in the increase in the liver transplant for alcoholic liver disease. Again, the alcoholic liver disease is the most common indication. Numbers are higher than the combining number of the NASH and the SCV. These are their demographic profile. Most of the patients are males. Median age is 45 years, and 92% were CLD. This alcoholic hepatitis based on histopathology, only 5 patients had, 22 patients presented with ACLF. Coexisting etiology, this was NASH present in 64 and hepatitis B and C in 24. Most of the patients were child C, and decompensation profile is majority had ascites. AKI HRS was seen in 1/3 of the patients. Sarcopenia was seen also in 1/3. Combined ascites and sarcopenia in 1/3. Most of them were childs and their high MELD score. Donors were majority were the wife and the first degree relatives. Their pre-transplant alcohol history, pre-transplant relapse was in 36% of the patient. 60% had a daily intake. Short abstinence less than 3 months was in 12%. 3 to 6 months in 20%. Median abstinence period was 13 months. In-hospital mortality post-transplant was 8%. Post-transplant sepsis was close to 36%, and almost 13% of the patient had a major morbidity. The post-transplant relapse was seen totally in 26% of the 26 patients, and 6 patients had a harmful use. It was defined by more than 4 drinks per day in women and more than 5 drinks in men. The time of relapse was majority after the 6 months. The survival analysis showed it was a comparable survival between the alcoholic versus non-alcoholic. Even that 5-year and 10-year survival were comparable. It was more than 80%. So conclusion that alcohol is now the leading indication for the liver transplant. Early liver transplant for alcoholic liver disease and alcoholic hepatitis can be life-saving. Accurate, objective, and consistent risk assessment for the post-LT alcohol relapse is critical to the LT selection and management and the excellent post-transplant outcome. Understanding of the key selection factor is evolving, and the further studies can improve the outcomes. Given associated with the poor outcome, especially the harmful alcohol use, interventions to prevent the treat alcohol relapses are needed. Thank you.